तीन लोग तो सो सकते हैं आराम से। अरे सपना ऊपर दीदी के लिए नीचे चला दे।
Priya,
Yes, sir, we shall start, sir.
I think we should
Doctor.
start,
Yes,
and
yes.
then I think people can join, no?
Yes, yes, sir. Jenny, please start your video and start the.
Good evening, everyone. Is my slide visible
Yeah.
and am I audible? Yeah.
Yes, yes.
So my case for today is a 56 years old gentleman who presented with complaints of pain at epigastric region since 1 month, decreased appetite since 1 month, nausea since 1 month, and weight loss of 18 kilograms in the last 1 month. The patient was apparently all right 1 month back when he started having sudden onset severe pain at epigastric region, which was continuous in nature, aggravated post meals, radiated to the back, and was relieved on bending forwards. The pain gradually decreased in intensity over the last month, and at present, the pain is dull aching in nature, located at the upper abdomen, and is radiating to the back. The pain was associated with multiple episodes of bilious vomiting initially, but currently there is no history of any vomiting. Patient was admitted at a local hospital in ward and was kept nil by mouth for 3 days during this acute episode, and the patient was discharged after 6 days and was tolerating liquid diet on discharge. He also complains of decreased appetite, early satiety, and nausea since initiation of pain. There is a history of weight loss of 18 kgs over the last 1 month. There is history of swelling over bilateral feet since 1 week. There is no history of fever, jaundice, no history of hematemesis, melena, or any abdominal trauma. Coming to the past history, there is no history of similar episodes in the past. Patient is a known case of type 2 diabetes mellitus, known hypothyroid, and there is no past surgical histories or any known drug allergies. Coming to the personal history, the patient has a mixed diet, but the appetite is reduced. Sleep is adequate. The bowel habits are 2 to 3 episodes per day, which is semi-solid in consistency. Bladder habits are normal. There is no history of alcohol or tobacco consumption. No history of similar episodes in the family, or no history of any malignancy in the family. So, coming to the general examination, the patient is conscious, cooperative,
Priya,
and
we should take an exam only after completion of examination or after history also. Sir? Because I would like to have a summary of history. Have you got the summary of history, Jainil?
no, sir. I'll summarize. A
Yeah.
56-year-old gentleman with acute episode of pain 1 month back in the epigastrium, which was continuous in nature, radiating to the back, relieved on bending forwards, and aggravated post meals, with history of bilious vomiting, which
No,
settled.
that is not a summary. You are repeating yourself. What are the salient point of history? Just tell me.
Epigastric pain radiating to the back, associated with multiple episodes of vomiting, so much enough so that the patient had to be admitted in the hospital and was kept nil by mouth and was discharged after six
That is
days.
not
Which
summary. So you have not prepared summary. Patient was admitted, kept nil by mouth. That is not summary. What is summary of history? I am asking you salient point. That this one point severe pain since 1 month, right? Associated with vomiting and significant
weight loss,
weight
weight
loss.
loss.
Agreed? So these are the
Yes, sir.
three without any significant past history. Have you asked history of blood transfusion in
So
past
there's
or at present?
no history of any blood transfusion in the
You have
past.
not asked history of blood transfusion. What is significance of blood transfusion in this patient? I don't know what is the patient is having, but significantly vomiting, severe pain which is radiating to back, and significant weight loss. How does the blood transfusion affect?
Any acute blood loss by a gastric ulcer perforation may
No, that will
require
be a
blood
present
transfusion.
history. And you must know that. How did an indirectly affect? Means, what are the diseases transmitted by blood transfusion?
Hepatitis,
What is long-term complication of that?
cirrhosis of liver,
Cirrhosis. Anything else?
portal
Right?
hypertension,
Portal hypertension is not a, we are talking of epigastric mass related to that. Hepatocellular carcinoma. Keep that. Following the hepatitis, it can lead to it. So, history of blood transfusion is important. Keep that thing in mind, particularly when we are presenting epigastric mass and significant weight loss. Right?
sir.
So, what is significance of vomiting in this particular patient? What did you think of before going to examination? Because then you will know what to examine. That's why I'm interrupting and would like to discuss history now.
Bilious vomiting may indicate some intestinal obstruction at that point of time,
Okay.
which may have severe vomiting.
Okay.
Also,
So
the other possible
what other thing you would like to ask in bilious vomiting? What was the nature of
projectile,
vomiting?
projectile and the content of the vomiting.
what is significance of projectile vom? When you say was it a projectile or regurgitating?
It was not a projectile vomiting.
So it was regurgitating.
Yes.
What is difference?
So in projectile vomiting, the vomitus is transmitted with a force.
And
So
what does it
perpendicularly.
suggest?
Any gastric outlet obstruction,
So do you think gastric outlet obstruction in this patient?
less likely, sir.
Less likely. Why? Why do you think it may not be a gastric outlet obstruction? You
Gastric outlet
yourself have
obstruction
said
pain
patient is
radiating
having
to the
bilious
back,
vomiting. Patient
bilious
is
vomiting,
having bilious vomiting. What is
bilious vomiting.
significance of that?
That the obstruction is distal to the second part of
Exactly.
duodenum.
So projectile vomiting, gastric outlet, or even proximal intestinal obstruction. And usually obstructive variant will give rise to projectile vomiting, whereas the other disease will give rise to regurgitating. So you should specify. Have you specified it? It was projectile?
No, sir.
No. So keep
It's
that
a
thing.
non-projectile.
It is.
Yes, sir.
It is not, right?
Dalvi sir, we can see that your hand is raised. You can please ask your question. You are one of our
Sir,
examiners.
you
need
don't
not
need
raise
to
a
raise
hand.
your hand.
Yes, sir.
No, Jailin, I just want to ask you, this is a 56-year-old patient who has severe pain, and you said it was radiating to back and he had to bend forward, etc., etc. When such a patient tells you something like this, what comes to your mind?
Acute pancreatitis is something
Okay, fine,
that comes to
fine,
mind.
fine. Any other thing that comes to your mind?
Any duodenal ulcer perforation may also present with similar pain.
No,
Septic
perforation
ulcer
will come
perforation.
as an emergency. Any other condition that will come to you with patient complaining of epigastric pain, radiating to back and has to bend forwards. That's what you said, right?
Biliary colic also sometimes the patient may have.
Agreed.
Epigastric
Any
and
other
RH
thing?
sequel. Choledocholithiasis may sometimes have that.
See,
Most characteristic.
you are going towards right hypochondrium. That's the problem. I am
Hmm.
sticking to epigastric region. Pancreatitis is one. Any other thing that you can think of out of the box? If you don't know, say don't know. Doesn't matter.
I
Now,
don't know,
this
sir.
is a patient who has loss of appetite and significant loss of weight, 18 kilograms in 1 month. When you combine these two complaints, pain and weight loss, 18 months, what are the diagnoses that come to your mind? See, I always
Duodenal.
believe that patient tells you everything, and this patient, according to me, we have still not gone into the examination, but it's already telling me what these two organs are going to be. Another significant history that you said that initially patient had vomiting, which was bilious, and then it
Stop.
stopped or did not become bilious. You mean the pilus, which was open, now has closed down? What is your thinking?
In the initial phase, the patient may be in obstruction which may got relieved because
Where
of which
is the
the
site of obstruction in your history? That's important. I think Dr. Pankaj Joshi tried to lead you to it, but I want it from your mouth.
duodenal means distal to the second part of duodenum and or the proximal small intestine.
Correct.
Very
Now,
good.
correct. Now, distal to the sphincter of Oddi, which are the conditions which give rise to pain radiating to back and obstruction distal to the papilla of Vater?
SMA syndrome can sometimes lead to.
Fair enough. See, you are presenting lump in abdomen. I know that. But I want to know when you examine such a patient, how do you go about thinking in the history that is given to you? Now, pain was associated with multiple episodes of bilious vomiting initially, but currently there is no history of vomiting. What does it tell you? That the obstruction has opened up?
Yes, I mean, whatever the cause of vomiting was, it has settled by now.
Very good. Now, that is exactly what I'm trying to ask you. Give me causes where obstruction gets relieved with history of pain radiating to back. If you don't know, say don't know. Let's go ahead.
I don't know, sir.
Okay, doesn't matter. Go ahead. पंकज भाई देख लो इसको.
हाँ ठीक है चलता है. So what sir was trying to tell you is that your case is epigastric lump. So we assume, we have not examined that, assume that there is a lump. There is a lump, severe pain, radiating to back. There was a probably either irritational or obstructive variant of the vomiting, which is now settled. So sir was asking what line you are thinking. Do you, and weight loss of 18 kg. So what you should be thinking?
Sequelae of acute pancreatitis, we should be
Uh,
thinking of.
okay, we'll go to examination and we'll come back later on. Because I don't know what point suggests it is acute pancreatitis.
So the
Which are the
epigastric
points
pain,
on your in history suggest patient is having acute pancreatitis?
epigastric pain radiating to the back,
Yeah.
aggravated post meals,
Hmm.
and associated with vomiting.
So the sir was saying that only vomiting was there, which has settled. Probably that might be the reason that patient has settled. Let us go in examination as sir has said, and we'll discuss that
Now,
later.
even before going to the examination,
Yes, sir.
Jainil, I want to ask you complications of duodenal ulcer or gastric ulcer.
There can be peritonitis
Correct?
because of this, or it can be a sealed off perforation, which can cause a localized abscess cavity.
Very good. So, if I have my memory correct, they are divided into acute, which can be perforation or bleeding, chronic, which can be obstruction, and subacute is labeled as perigastric abscess. So, can you fit in your this?
Perigastric abscess can lead
Very
to
good.
similar
Can present as lump
symptoms.
in abdomen
Yes,
and
sir.
give all these complications, including the symptoms that you have tried to say. Okay?
Yes, sir.
We have not yet gone to the examination.
Yeah.
I'm just trying to tell you that
Right.
there are diagnoses in mind
Hmm.
which you can keep if you have read well. It's okay.
Right.
Go ahead with
So
examination.
I think you are biased on pancreatitis because probably it might be pseudocyst. That's what you are in thinking of top. But at present scenario, there is not a definite evidence that it has to be a pancreatitis. So keep other options open, including malignancy, because of the 18
Yes, sir.
kg weight loss. That should be kept in mind. Okay. Proceed to examination. Yeah.
On general examination, the patient is conscious, cooperative, and well oriented to time, place, and person. Is well built and well nourished with a BMI of 30 kg per meter square. There is pitting pedal edema present over bilateral feet. No pallor, icterus, clubbing, cyanosis, or lymphadenopathy. The patient is afebrile, the pulse being 92 beats per minute. Blood pressure is 100 by 60 millimeters of mercury measured over the right brachial artery in supine position. The respiratory rate is 16 per minute. On inspection, the abdomen is distended. There is fullness present over the epigastric region. Umbilicus is central in position and inverted. There are no scars or sinuses seen over the abdomen. No visible peristalsis can be seen, and the hernial sites are normal. On palpation, there is no
Just
local
wait
rise of.
here. Just wait here.
Yes,
Go
sir.
back to the first. Abdomen is distended. What do you mean by this?
Means it's not scaphoid; it's distended in shape.
How do you describe distension of abdomen?
Uh, if we look at a 90-degree angle to the perpendicular of the abdomen, it should be
No,
flat,
no,
but
no,
it
no, no, no.
is
Let me get in here. There is something known as central distension and generalized distension. When do you get central distension and when do you get generalized distension?
central distension can be seen in obesity.
Let's talk of pathological states rather than generalized states.
In that, actually, when it is obesity, you don't call it distension. Right? So, one more point, why you are in trouble? You have written distended. You have not written generalized or localized or central like that. Do you understand? So, whole abdomen is distended. From your finding, that's what sir is trying to tell you.
It's more in the upper abdomen. It's distended and there is a fullness in the upper abdomen. Not
So you should
generalized
say
distension.
that.
Yes. Yes,
That's
sir.
Okay, because central distension means small intestinal obstruction. General distension could be colonic or paralytic ileus. Okay, go ahead.
or ascites in some cases.
Yeah.
You have not written this dilated veins. You should in that no dilated veins. That
Tarun,
should
you
also.
have joined. Sorry. Then
Tarun,
I
Tarun
will not
Oh,
sir,
sir,
explain.
sir,
welcome,
I have joined.
welcome.
I
I
missed
joined
you.
before only. Actually, it was showing Anmol name because it's logged in through our Delhi State chapter,
No
sir. He's
problem.
our,
No problem. No problem.
Okay, welcome Tarun sir.
welcome, sir. Thank you, sir.
Okay, yes, uh, Dr. Mittal has asked you, go back that inspection part. You have said no visible peristalsis, scars and sinus. Hmm. Why it is important to look for a visible veins? That's what the question was.
So there can be caput medusae if there is a underlying portal hypertension, which may be possible if there's a liver pathology we are dealing with.
Only caput medusae will look for. What other types of vein you can see? In flank also. Keep that thing in mind. It can be in flank or in center. One more point when you are talking of distension, have you discounted patient is hypothyroid? I think.
Yes, sir.
Right. Okay. Go to palpation.
All quadrants moving well with respiration or respiration, there is any movement of lump. You should tell that also if it is seen.
Okay, sir. I have actually said it in palpation.
No, 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 no. In inspection also, you have written fullness. So there is no apparent lump according to you. On inspection, no lump is visible,
Only fullness was seen in the epigastric region.
but no
On
lump.
inspection. No lump. On inspection, no,
Ill-defined
only
lump
fullness.
or ill-defined lump or nothing is visible that way.
Means there is a full means there is some amount of fullness in the epigastric region, so it's uneven, the upper abdomen and lower abdomen.
What is that? I don't get it. What do you mean by uneven?
Means epigastric region is little means there is a external cover because of the lump. There is something visible in the epigastrium. Wanted to mean, but clearly the lump was not able to. We weren't able to see the lump.
Okay. So remain on one side. So there is no visible lump. That's all. Something uneven, this, that. It doesn't make anything. You understand? Simply stick to
Yes.
that. No lump is visible. Only fullness according to you. Right? So is it same as distended abdomen or is it different? At the Dalvi sir was asking.
Distension will be generalized more.
Will be nahi in
Fullness
this
will be
patient.
localized.
In this patient. We are talking of this patient. So abdomen is generalized distended with fullness. What do you want to say? Okay, forget about it. Later discuss after palpation. Go to palpation now. Show it. Hmm.
On palpation, there is no local rise of temperature or tenderness. A 13 by 10 centimeter lump is palpable in the epigastric region, which is globular in shape with irregular margins, irregular surface, and is firm in consistency, extending horizontally from right midclavicular line to 5 centimeter medial to the left midclavicular line, and vertically from 2 centimeters below the xiphisternum, 2 centimeters above the umbilicus. It does not move with respiration. It is non-mobile, non-tender, and non-pulsatile. There is no localized guarding or rigidity. The liver, spleen, and kidneys are not palpable. On percussion, dull note is present over the lump, and tympanic note is present over rest of abdomen. The liver dullness is noted in the fifth intercostal space, and the dullness of the lump is separate from the liver dullness with a zone of tympanic in between them. And there is no signs of ascites. On auscultation, the bowel sounds are present, and there is no bruit heard over the lump. On systemic examination, patient is conscious, oriented, no focal neurological deficit. S1, S2 present, no audible murmurs. Bilateral air entry is equal, and spine examination is normal.
Okay.
Uh,
So is it a
coming to my
diagnosis or is it summary?
summary,
Don't put a heading of diagnosis. Diagnosis is only one few words, not a essay. This is summary. Okay.
yes. So, a 56 years old gentleman with complaining of dull aching epigastric pain radiated to the back and decreased appetite with weight loss, with history of acute episode of pain 1 month back, who on examination had a 13 by 10 centimeter non-tender lump in the epigastric region, which did not move with respiration, is most probably a case of walled-off pancreatic necrosis with no signs of infection.
Okay. So what is your diagnosis? Provisional diagnosis?
Walled-off pancreatic necrosis.
So how is it different from pseudocyst?
A pseudocyst will have well-defined margins, but walled of pancreatic necrosis will be ill-defined and irregular in
So
consistency.
what did you say in palpation? To go back to palpation?
Irregular
Margin.
margins, surface and
Irregular
curve.
or ill-defined? These two are
Ill-defined.
different things. That's what I wanted to discuss. Have you done PR?
No, sir.
Why not? Is it part of examination or not?
Yes, sir.
Okay, at least if you have not done, but mention that, or patient did not allow, or whatever it is. In exam, sometimes it does happen that patient may not allow, or expert will tell you don't do it, but mention that, sir, I would like to do PR, but was not done. That is a different than forgetting it completely. Because
I'll come in here.
yeah, sir,
Jainil, defend yourself if I tell you the diagnosis is a huge perigastric abscess because of perforation of malignancy with deposits in the pouch of Douglas. Now you have to defend one, the first diagnosis. Second is why you have not done PR.
So perigastric abscess is one of the differential diagnoses, which I would like to keep in mind.
What will happen in perigastric abscess, which will not happen in ward of pancreatic necrosis?
There will be
Fever will be
fever.
there. Weight loss will be there, especially in malignancy of the stomach. We are asking you clinical examination. You have reached a diagnosis. I am giving you alternative diagnosis, and that you have not done a PR. That is exactly what Dr. Modi was trying to ask you. See, in examination, whenever, of course, I can understand you never thought of the diagnosis, but complete the examination so that you are safe. Tarun, you can come in.
Also, why not a very large cystic pancreatic neoplasm with duct involvement and pancreatitis?
If it's cystic, then it won't be dull on percussion. It will be some
That
tympanic.
that should not be an issue. But you should always have a differential diagnosis, na?
Yes, sir. Yes, sir.
Not any of these things as differential diagnosis. And this walled of pancreatic necrosis versus pseudocyst, that is more on CT scan. If there is necrosis, then it becomes walled of pancreatic necrosis. And if there is no necrosis, then it becomes more of pseudocyst. So that also you
Yes, sir.
cannot see on your examination.
Yes, sir.
That should be on more after investigation. So
Yes, sir.
because you know the diagnosis, you are going backward. That is your main problem. It should be other way around.
Yeah. That's what I was trying to say. Why everybody I advise that do not put a one diagnosis. Always think of more than one thing. And remember, the clinical diagnosis doesn't mean you have to be right all the time. You can put up so many diagnoses. Why specific only Waldorf pancreatic necrosis? What is the point favoring Waldorf pancreatic necrosis? Did patient have a fever?
No, sir, there was no history of fever.
No history of fever. Right. Okay. Any other significant? Was the CT scan done in 1 month?
Yes, sir. After admission, a CT scan was done.
Yeah. Right. Okay. So now the question is that you have an irregular margin. I'm coming back to that. So what is difference between ill-defined and irregular?
Ill-defined is we cannot make out the margins, whereas
Mhm.
irregular is we are able to make out the margins, but it is irregular in shape. It is
So
not smooth.
do you think that it is not cystic? You want to say
Yes, sir. It's not cystic in
it is not cystic. An irregular surface. What may be the cause for that?
the necrosis can be sometimes irregular because it's not
So
uniform
what you are palpating is necrosis.
on the wall of the necrosis.
No, irregular surface, the necrosis. Which part get necros? In this,
Usually,
yes,
the head is more likely
pancreas. Pancreas.
head of
Agree?
pancreas. Yes, sir.
Right? So will you able to palpate that necrosis? I don't think so. Right? What does give the irregular surface? What happens? Suppose you are thinking of pancreatic necrosis, which other things occur along with that? What happens to momentum?
There will be omental fat stranding.
No, we are talking of
Means
clinical.
deposit.
So clinical, you can say mental head
uh,
stranding. We are talking clinical. I'm not asking
clumping,
CT or USG report.
a clumping of the omentum over the
Rolled up,
epigastric.
clumping, and it may be palpable. Usually in initial pancreatitis, irregular surface is given by those things. You can say
Yes,
that it's a other word which is used is phlegmon or inflammation, which gives rise to irregular. So you want to say it is not cystic. Agreed?
yes,
It is
sir.
not cystic in consistency, right? That's
Yes,
what
sir.
your written form, right? So why you are
Yes, sir.
thinking of walled-up pancreatic necrosis? What are the content
Given
of walled-up pancreatic necrosis? What we call WOPN.
the necrosum, if there is any hematoma or necrosed part of the head or means any part of the pancreas will be there.
That's it. What else you are able to, which
Some
make it
fluid,
WPN? There will be a lot of fluid. Fluid will be
fluid.
there. It not completely cystic, but fluid is also major part of. That's why it is known as walled off pancreatic necrosis.
Yes,
And I don't think you should put that diagnosis only. Dr. Mittal, what do you want to say about that? Because I don't agree with that diagnosis.
Yes, sir. There can be many diagnoses, and
Hmm.
I think we should have given some differential diagnosis, not just provisional diagnosis.
Hmm.
And then take on the things. Like sir said, gastric abscess can be there, malignancy can be there, presenting.
How will you explain 18 kg weight loss?
because of the decreased appetite and decreased intake. Uh,
Was there recurrent vomiting? Can you explain this? A patient is not able to eat because of fullness. Ma
so,
just
so initially there was vomiting, but later on the patient was not able to eat food generally. That's why liquids he was tolerating, soft diet was not able to take much. And initially also he was obese. So his weight was 98 kgs, which decreased to 88, which decreased to 80 kgs.
okay.
Okay. Right. Great. So, would you like to put any other or straightway we'll go to investigation?
My other differentials would be like Dalvi sir said, sealed off perforation with a localized abscess, perigastric abscess, or
Mhm.
even a duodenal abscess can be one of the
Okay,
differential
agreed.
diagnoses.
Anything else? Any
And
other?
gist of the duodenum is one of the possibilities which can present with similar complaints. Gastrointestinal stromal tumor.
Mhm. It will become this large in 1 month.
If there is a hemorrhage, it can sometimes.
Jainil, 1 minute. Why do you get into gastrointestinal stromal tumor at this stage?
Hmm.
Because the size, sir, usually other
You
malignancies don't.
forgotten the history. Now you are looking at examination only. See, these sort of things make examiners, uh, you know, you should not get into it. You are on Waldorf pancreatic necrosis, and there are some one or two other things. Don't get into solid tumors without considering the history.
Yes,
This
sir.
is for all PGs who are attending. You try to deviate away, and the entire questions will go on stromal tumors, and you will be in trouble. So try to stick to your diagnosis, okay?
The
Yes.
point here is that that's why I ask irregular margin. You are telling me it will be very well defined tumor. It will not be ill defined. History will be longer. And so think of that. Why not liver abscess? I was dying to ask this question. From your history and examination, why you did not put a differential diagnosis of liver abscess or rupture liver abscess?
So there was no history of fever in the beginning,
Okay.
and
So that will
on
not, even in acute pancreatitis, there will be history of fever. It is so, there's not point is that. Okay. What else?
examination we were able to see that the lump which was palpable was different from the liver. There was a zone of
Mhm.
resonance in between.
So why it is not from liver? Very basic question I am asking you. You say it is not from liver. Why? Clinically.
If it would be liver, then the dullness would be continuous, going downwards towards the lump on
Okay.
percussion,
One is that.
and it moves with respiration. A liver abscess,
This is not moving with respiration.
not moving with respiration.
What
Daniel,
else?
I'll come in here. What
Yeah.
he's trying to ask you is, have you decided where is the lump situated?
Yes, exactly.
Anatomically, where is the lump situated? Is it intraperitoneal or retroperitoneal?
Retroperitoneal, sir.
Very good.
Very
So
good.
the question of liver abscess doesn't come in.
Exactly. You should say the first thing you should mention is does not move with respiration. Mobility in some cases you should say and separate from liver.
So
Agreed?
now
Yes,
you
sir.
have got a patient with lump in abdomen, which according to you and me is retroperitoneal on examination, which has presented to you with acute pain, etc., whatever you have said, and you are palpating a irregular lump. The irregularity, I think Dr. Modi has already told you why it occurs. So now you have to zero in on different diagnosis. Number one is pancreas. Number two, posterior stomach. Number three, organs in the retroperitoneum which come in that area vis-a-vis the aorta and the IVC. So now you decide and go ahead with discussion. Because I'm sure Dr. Modi or Dr. Mittal is not going to ask you questions on WPN which you have read and come.
Because this is what happens. This is for all PGs. Because when we suspect that you are realize that there is only one diagnosis, then you are in trouble. Whether you are right or wrong is never an issue. Keep that thing in mind.
Yes, sir.
Okay. So you should understand that. So again, my old question: why not pseudocyst?
I would like to investigate further in order to
Clinically, I am
rule out
not saying it
possibility.
is pseudosis. Don't take it that I am thinking, but some exam. This whole platform is to give you the various questions which can trouble you. So why not pseudosis? Yes, obviously we will investigate, but clinically, can you say from you yourself have said? I just want repetition.
Ill-defined margins, one of the factors, and dull note on percussion.
Hmm.
That's why
That's
I
it.
would.
So
Hmm.
cystic will have a tympanic knot. That's what you want to tell me. You said that at that time. I just let it go. You want to say if the lump is cystic, will have a resonant knot or tympanic knot. No, it's not like that. Pseudocyst will have a dull knot. Why it should be tympanic knot? The fluid doesn't give tympanic knot. Right? So so the question's answer is, sir, it is a short history. One. Second, still no well-defined lump. It is still irregular margin with more of a solid content and form. So it may develop later on, but at present, it doesn't seem to be like that. Okay. Mittal sir, would you like
Yes,
to
sir.
ask anything?
We should start with the other things like what investigation he has done and
Yes.
what. Yes.
Okay. So as the Dalvi sir and I am also saying, put more than one DD. It will help you for a discussion also. And gist is not a diagnosis. Even if CT says it is gist, from your history, it should not be put. Do you understand? So there is a
Yes, sir.
difference. Your diagnosis should be based on clinical findings you have given us. Right?
Yes,
Okay.
sir.
Now what will you like to do?
I would like to do basic investigations first. Like I want to do a complete blood count. I would like to do creatinine to see whether it's dehydrated or not. I would like to do a liver function test to
Wait, but, do you think you should say like this that we will test, or you should say like first I will confirm my diagnosis, then stage it, and then routine, or is it other way around?
I didn't get the question. Sorry, sir.
What sir is asking, the point here is that should you tell the routine investigation first or a definite which will give you the diagnosis first?
Uh,
So, Mittal
okay.
sir, uh,
So
it
that
can
is
be
why,
both way round.
yeah, it
Sorry.
can be way around,
Hmm.
but really it is better to test to confirm your diagnosis. Then is comes the fitness and other things.
Yeah. But there are certain investigation, though they are other than definitive, but they are not routine. You said complete blood count. What is significant here?
Yeah.
uh, so I would like to see for any anemia because there is 18 kg weight loss. Secondly, I would like to see the WBC counts, whether or
Hmm.
not there is some infective
So
pathology.
clinically patient is anemic?
No pallor, sir.
No pallor. So yes, count is very important. What else?
The hematocrit, whether or not he is dehydrated,
Why you are insisting on dehydration? This is
because
second time, sir. So creatinine will give you idea whether patient is dehydrated or not.
uh, means the kidney function will be able to assess with the creatinine.
So you have done a general examination,
He is
right?
not clinically not dehydrated. Yes,
So
sir.
why you are in? So these are the important point. And see the investigation, say tell about them, and let the examiner ask the question. Why you are judging that if creatinine is normal, patient is not dehydrated? Rather, one more investigation I would like is TSH.
Hmm.
Because
Yes, sir.
you have to give. So have you said the drug history? How much thyroxine he or she is taking? I have forgotten the male or female. Sorry,
He is taking, sir, 100 microgram of thyroxine.
that you should have
Consider.
mentioned in your drug history. Fine.
Yes, sir.
So those are the some routine investigation you will do. So which specific investigation you will do to reach your diagnosis?
I would first like to do a USG abdomen to identify, localize the organ of origin of the lump to see whether or not its content is solid or a cystic content,
Hmm.
and to see the surrounding organs like liver also.
Right.
And
Mittal sir? Yeah.
anything else?
Can
Anything else?
For the free fluid in
I'll
the
ask you a
abdomen,
question.
So
here.
many things are there which you should know. You're
Yeah.
just
So I'm just extending what Tarun is trying to ask you. When you send this patient for ultrasound examination with a diagnosis of walled off pancreatic necrosis, what is the information you would like to have from a sonologist? One, you said organ of origin. What else?
I would like to have a look at the liver, the ecogenicity of liver, whether the CBD
Let's
is
say it is
dilated or not,
normal. Let's say it is normal,
whether the CBD is dilated or not.
not dilated.
And I would like to like the him to have a look at the portal vein and the splenic vein to see for any thrombosis.
Very good.
Uh, I would like to have a look at the spleen also, whether any splenomegaly is there or not.
So, Jainil, you have to have a protocol. You cannot just answer here and there. So, once you look at the organ of origin, you have to also tell me what are you looking at from the sonologist, the contents.
Mm.
Yes, sir.
and
Whether it's a
volume.
cystic volume, size, whether the content is solid or a cystic component.
So, just remember one thing for the benefit of people who have joined as PGs. When you ask for ultrasound, CT, MR, whatever investigation you ask for imaging, first organ of origin, local things that happen because of whatever has happened in that area. Then you go to the next complications that can occur, like you said, splenic vein thrombosis or portal vein thrombosis, and then you spread out to the other organs. Once other organs are done, you got to also look at the peritoneal cavity. So if you have this pro forma in mind, it will be very easy for all of you all to answer these questions if you are asked about USG, CT scan, or MR. You understand?
Yes, sir.
And then it is very musical to examiners' ears that you know what you're looking for. That's the way I would go about it. Go ahead.
And sir, gallstone, he has not said at all. You
No,
have.
Gallbladder. Yes.
he hovered around CBD,
Ah,
etc., etc.
so the most important thing is what is the etiology of this pancreatitis, and most commonly it is gallstone, and you have not talked
Also,
of.
sir.
Hmm. Equally important is give more important when you are talking obviously about free fluid. What is
Yes, sir.
free fluid?
Ascites.
Ascites. Right. Why we use word free fluid? In this case, it will be very important.
So there can be pancreatic ascites. Means
One, very good. What else?
if the necrosum is ruptured at one place, it may lead to free fluid in the abdomen. Or if it's a
Even without
pseudocyst, if it
rupture,
is
there can be
ruptured,
a free fluid, reactionary fluid, pancreatic ascites, those are the known. Second, but the point is that there may not be only free fluid. There can be confined fluid, there can be one cyst or multiple collection can be there. It may not be, you are palpating one walled of pancreatic necrosis, there can be others also. Do you understand?
yes, sir.
So those
Yes,
are
sir.
the points you should say. And as sir has said, Goldstone is a very important point, right?
Yes, sir.
Okay. What is significance of saying splenic vein in this patient?
One of the
Sir
known
mentioned something
complication,
about that.
one of the known complication is a splenic vein thrombosis in these
Thrombosis.
patients.
And it is a short history, thrombosis is, or even formation of multiple collaterals because of the pressure.
Yes, sir.
Okay. So have you got the USG report?
No, sir. Unfortunately, I have not got the reports in this.
You don't have a report. Oral also?
Yes, sir. Orally, sir, there was no gallbladder stones. There was a 13 by 10 centimeter uh, solid means lump in the epigastric region with ill-defined margins. They said irregular margins and ill-defined in shape
Okay.
with both
So
cystic
what
as
was
well as
the
solid
conclusion
component
from
remaining.
USG? So we can go further. What
So
was the conclusion from that?
the
They must
exact
have given
extent,
suspicious of these that.
yes, sir, they have given suspicious of a walled off pancreatic necrosis.
Okay. Okay,
with
so now
no
what
gallstones.
will you do now?
I would like to further investigate it with a CECT abdomen with oral and
Hmm.
IV contrast.
Why?
I would like to know the exact extent of the lump, the
Hmm.
organs it is in close proximity with, and to plan whether or not there is a wall, whether it is a pseudocyst versus a wall of necrosis,
The point
whether
is
the
that how
wall has
much time
developed.
has passed since starting of symptoms?
1 month, sir.
1 month. So are you planning any intervention or not?
So
Pankaj bhai,
clinically,
एक minute.
Sorry, yes, sir.
It is 1 month.
1 month.
yes,
And
sir.
you are still harping on Waldorf pancreatic necrosis rather than a pseudocyst.
Pseudosis. That's what I am trying to ask him. So are you planning some intervention or keeping patient conservative?
Uh, for now, sir, conservative.
Conservative. So why do you want to do CT? So from USG point of view, are you suspecting anything other than Waldorf? Because US CT at this present patient is discharged at home stable according to your parameters. So why you want to do CT? You have said, "No, I'll go for a CT." Why? So you should have read properly. What are the indication of CT scan in such scenario?
Pankaj bhai, I'll ask him theory.
Okay, please, sir. Thank you.
Because I
Huh.
think he's well read in theory.
Theory.
So practically he's going to make a mess.
Okay,
So
sir, ask
tell me
please.
something about Atlanta classification of acute pancreatitis and where does WPN come in and where does pseudocyst come in?
Sir, Atlanta classification differentiate pancreatitis into mild, moderate, and severe. Uh, it depends on the presence of any local complications or systemic complications. So if
No,
there
no,
are
no, no,
no
no. 1 minute. Let's stick between pseudocyst of pancreas and Waldorf pancreatic necrosis. Where does it come in Atlanta?
after 4 weeks, if there is a means initially if there is a acute pancreatic fluid collection, or we can say an acute edematous pancreatitis, it can lead to a pseudocyst formation. Whereas if it's a necrotizing pancreatitis, it leads to a walled of pancreatic necrosis
Correct. So when does pseudocyst come in and when does Waldorf pancreatic necrosis come in according to Atlanta classification?
after four
Because
weeks,
your patient has only 1 month history.
after 4 to 6 weeks. Yeah.
Now you're jumping between 4 and 6. Be very clear what is in Atlanta classification.
4 weeks, sir, in Atlanta.
So now would you like to change your diagnosis into pseudocyst rather than a Waldorf pancreatic necrosis? You still want to say no. Fair enough.
Based on the imaging, I would like to. Uh,
No, no. Imaging doesn't come into picture here. Even if imaging comes into picture, show me a CT scan or something like that to support your diagnosis.
uh, Fluid component along with solid component, both of them are being there with a
That can
indefinite
be there,
margin is
there
not.
in pseudocyst as well.
Hmm.
So when examiner is trying to lead you to some answer, it is better to hear to the examiner than be rigid because you know the investigations.
So he is respecting radiologist.
Yeah.
Do you understand? So what we are trying to tell you is that would you like to put a pseudocyst as a part of your diagnosis or not? Because
Yes, sir.
repeatedly I asked him, was there a fluid content? Was there this? 1 month has passed. Sir is also asking, right? But
Yes, sir.
because the USG people had written WOPN, you are sticking to that. That is clinically also you along with Waldorf. Well, rather I would put a developing pseudocyst as a first possibility, right? Because if it is a Waldorf pancreatic necrosis, patient will not be that stable. Do you understand? That's why I also hinted that patient is discharged at home, vomiting has stopped, everything is so it is, inflammation is decreasing, and ultimately WPN will convert into either pseudocyst or abscess, or in mild case, Marycrest. Do you understand? The sir is
Yes, sir.
asking you the same. Do you understand?
Yes, sir.
So if if you are thinking of Waldorf pancreatic necrosis, is there a role of CT at present? Do you understand my question? I hope.
Yes, sir.
So, why
Okay,
would you like
I'll
to?
ask him the question other way around.
Okay, sir.
You get the CT scan done, Jaimir. What are the things? Forget whether it is pseudocyst or Waldorf pancreatic necrosis. From treatment point of view, what are the things you're looking at in a CT scan?
Whether or not it's causing extrinsic compression of the surrounding structures
It
like
is
stomach or
not. Patient has
duodenum.
improved.
Whether or not there is a pseudoaneurysm that I would like to.
Now see, you are going to pseudoaneurysm without any reason. Again for PGs. Now I will ask you a question. If there is pseudoaneurysm, what, how does this patient present to you? So this is what happens when you read too much and you don't focus on the patient. Patient of pseudoaneurysm usually presents with a condition which is known as double rupture. Do you know what is double rupture?
Yes, sir.
What
Uh,
is it?
there is a rupture of the pseudoaneurysm into the pseudocyst, and the
Very
pseudocyst
good.
has ruptured into the stomach.
Very
So
good.
it causes
Very nice.
hematomesis.
Very nice. Can you tell me the symptomatology of such a patient?
Hematomesis or
No,
melena.
it never happens like that. That's why I asked you. Double rupture means symptomatology, and just on history, you can make out whether this is a pseudoaneurysm. Okay. Have you read about it or forget about it? For benefit of the PGs, as it starts bleeding into the pseudocyst, the tension in the pseudocyst increases, patient has severe pain. Then it ruptures into the stomach, leading to hematomesis, and the pain is relieved. And if this repeatedly occurs, you can have in mind a diagnosis of pseudoaneurysm. Do you realize what I'm trying to say?
Yes, sir.
Yeah, good. Very nice. Very nice. So let's not get into pseudoaneurysm. This patient has a cystic lesion in the lesser sac, and you want to decide a treatment, surgical treatment. Let's go. It's either cystogastrostomy or it is cystogegnostomy. On CT
Yes, sir.
scan, how will you decide whether this patient requires jejunostomy or a gastrostomy?
And whether
If
surgery is
it's
required or not, whether you
No,
can
no,
do this.
I'm not getting into Tarun endoscopic treatment right now.
No, 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 sir. Like he has not talked of wall thickness of the cyst.
So
What is the wall? Yeah.
let him. Yeah, go ahead. Go ahead.
it's
Yes, sir.
if it is in close proximity with the wall of the stomach, we may plan a cystogastrostomy. But if it is not, then we may need to do a cystogegnostomy for him.
So, will you suppose you are planning it tomorrow? Surgery?
No, sir, we
Or-
are not planning surgery.
Okay. So again, the question comes that when you are doing CT, it is done for some purpose.
Yes, sir.
You understand? As Tarun sir was asking, what he was talking about, did you understand? His
Wall thickness, whether or not it's completely a cyst or it's not completely has a full wall thickening or full wall around it or not.
oh no no no
That we
no,
need to see.
you don't get it. You don't get it. What he was talking, what full wall thickness? Not fullness, wall thickness he was talking about.
Wall,
Mittal sir,
yes, the wall thick.
explain it to him because I think he has completely misunderstood your question.
The thickness of the wall has to be there. So if you do the anastomosis, that it should stay. So minimum 6 mm. You would have heard the rule of 6 mm, 6 centimeter, 6 weeks, 6 mm. Have you heard?
Yes, sir.
What is that?
What is it?
Uh, the wall should be at least 6 millimeters, and we should wait for 6 weeks before planning the procedure.
Hmm. Hmm.
And 6 centimeters. And that was initially it was said 6 centimeters. Now is it same or is that changed? Centimeter is centimeter important or not?
I don't have any idea, sir.
So now it is more on symptoms, whether patient is symptomatic or not. If asymptomatic, you might not operate a 7 centimeter also, if it is asymptomatic.
So why we do not operate more less than 6 centimeter size pseudocyst?
So they spontaneously resolve in most
That's
cases.
why. And that's why I was asking why you want to do CT now.
Yes, we'll wait wait if
So,
the patient is
so what is
clinically
the
well, then we'll wait.
protocol? According to the protocol, when will you do CT in acute pancreatitis?
So at least after 48 to 72 hours,
Hmm?
the first CT,
Why?
because it takes some time to for the changes of pancreatitis to set in. If there is a diagnostic dilemma, then we may plan a CT earlier. But
Okay. But after
uh,
72 hours, why will you do CT?
to look for whether or not there is a necrotizing pancreatitis or an edematous pancreatitis.
So will it make any difference in management?
Uh,
So the
Management
criteria
will.
is that for first 2 3 days, CT if the dilemma of diagnosis. You are suspecting pancreatitis, amyloid lipase is not or other investigation does not support, and there is a possibility of other diagnosis that otherwise it is done after at least 72 hours or even later, depends upon whether the patient is stable, non-stable like that. After that, repeat CT, when will you do?
After 1 week, the last
Why?
CT,
Why?
to see the progress of the whether it's a acute
Again, it depends upon
necrotizing.
the patient. Whether the patient is improving, parameters are improving, you may delay it. But why will you do at the end of 1 month?
To look for whether or not there is a pseudocyst or a ward of necrosis.
So ultrasonography will not say it. So surgery, if planned, then only we'll do it or in dilemma whether to plan surgery or not. But at the end of vein, yes, you have done it's fine. You can wait for 15 more days before if the patient is quite stable and parameters are not there. Right?
Yes, sir.
So now the
Yes.
CT scan is done. As the Tarun sir was asking, what are the things you will look for in CT? Rule of six we have already discussed. What else you will look for?
The content of the cyst,
Amount of necrosis
amount of
inside.
necrosis,
Right.
surrounding structures. I would like to see whether
Hmm.
it's causing any extra. Clinically, there is no compression, but there might be a small amount of compression
On what?
of the
Compression.
stomach.
Is it bad or good?
If surgically, if we are planning, it will be good,
And
but
not planning, then also it is not good.
it will
Remember,
need to
if there is a
decrease.
pseudocyst, it mostly, unless it is some remote places, most of the pseudocysts are in lesser sac, will compress on stomach. It's a natural thing. Hmm. What else? Other things. Important point is that sometimes CT will help you if there are possibility there might be more than one cyst, pseudocyst, or the collection at other places, which will help you to defer the management. Tarun sir, would you like to ask anything? I think I have asked enough.
I think now we just after this, what will be your plan of action? This is the city, and it is same size. It is just 1 month. What will you do now?
I would wait and watch. I would
Hmm.
see how the patient is clinically, and depending on whether the patient has any fever or not, then I'll plan at least wait for 2 more weeks till we plan anything
So if
surgically.
after 2 weeks the size decreases to 10 by 8 centimeter, what will you do?
If the size decreases and the patient is clinically well, then we would like to wait and watch for it to spontaneously resolve.
Yeah, yeah, yeah. So not necessarily all the patient has to be operated, but if patient is symptomatic, is having pain or is recurrent vomiting is happening, and then you can operate. And supposedly patient has gallstones, what will you do?
I would
Along
advise
with cyst.
cholecystectomy. uh,
When?
I would advise cholecystectomy after the episode of pancreatitis settles, means the WOPN settles.
So if patient has mild pancreatitis, then what will you do?
Patient has mild pancreatitis, I would advise in the same hospitalization to do
Okay.
a laparoscopic cholecystectomy.
So what will you do if patient is symptomatic and has 13 by 10 centimeter at 6 weeks? What surgery will you do?
Uh, Cystogastrostomy
How?
or a
How?
cystogeginostomy, depending on the location.
Uh, 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 how will you do it? It's open laparoscopy, or have you seen? Have you done?
Laparoscopic, we would prefer. I have not done, but I've seen laparoscopic
Okay.
cystogastrostomy.
So how?
Jaimin, I have one question for you. What are the emergency indications of intervention in fluid collections around the pancreas or WPN that you will have to intervene?
If there is any infection of the
That is
WOPN,
one.
there is any hemorrhage into the WOPN.
Second, there are four. You have finished two.
Rupture?
Rupture of the yes, rupture of the pseudocyst.
Jaundice and obstruction. So these are the four things that you look at in treating any fluid collection in and around the pancreas. Bleeding comes last, actually. It's obstruction, jaundice, which come first. So you got to, decide when you want to intervene. Now, let's say this is a patient who is 1 month, has obstruction, has not stopped vomiting. What interventions will you do?
So
It's
if
purely
the
because of the size and pressure on the duodenum that obstruction is occurring. What are the options in front of you?
if there is wall thickness is there, then I would like to do an endoscopic drainage. Or if it is not possible, I would like to do a percutaneous drainage of
No,
the.
no, before that, it's just 4 weeks.
Then the percutaneous drainage will be a better option
Oh, if there's no fever, why will you do drainage?
because of the compressive symptoms
You
not
can plug
occurring.
the NG tube now for feeding.
So you have two options in
Elec-
front of you, Jaimil. One is a NJ tube and the second is intervention. Whatever you prefer.
NJ tube, NJ
The
tube would be
aim
better.
is to relieve the obstruction. That is the issue. Okay,
NJ tube will be better
correct.
in
Now
that
let's say
scenario.
this patient has jaundice. What will you do? No obstruction, patient has jaundice. Obstructive jaundice. What will you do?
Uh, so we'll see the cause of the jaundice, whether it's an extrinsic compression
It is
or
compression. Let us look at compression. It's not gallstone.
then I would like to do a percutaneous drainage in that case.
That is one option. You don't want to send the patient for ERCP and stenting. You think it will fail?
It is one option, sir. One possible ERCP
So
stenting
you
may be
got to
helpful.
have
But there is
options, right? So ERCP stenting is a better option than percutaneous transhepatic drainage. Why?
because it is less invasive.
What is less invasive?
Means there is no external catheter or anything like that in that, and it
Jainil, sorry, sir. Uh, Percutaneous drainage means you were transhepatic or you are taking percutaneous drainage of cyst or WPN? What were you thinking?
I was thinking of cyst, percutaneous drainage of cyst
Okay.
to relieve the compression,
That should be
and then to
avoidable.
go ahead with a step up approach. We may then later on.
Now see, Jaimin, you got into talking of step-up approach. This is what I would not expect a PG to talk about. Now, what is a step-down approach? You said step up, right? I did not say. Nobody said. Hello?
Yes, sir.
Ah. So do not talk of words which you do not know the corollary to it in examination. You will get
Yes, sir.
into trouble. I'm just trying to point out to people who are listening, PGs, that you be very careful when you utter some words. So let me know what is the step up approach.
So first we'd like to do a percutaneous drainage, and later on we may plan a video assisted retroperitoneal drainage and upregulate the catheters and put drains there so that we can remove all the necrosum.
Since you are talking about this, let me ask you a question. What are the endoscopic measures to remove the entire necrosum?
Endoscopic necrosectomy can be done.
Yeah, so how is it done? Have you seen?
No, sir, I have not seen.
It's okay. Does not matter. Don't worry about it. Okay. Let's go on to further treatment of this patient. You have done uh, whatever procedure and the patient is looking good. How do you manage it? Is non-alcoholic, as I see, right?
Non-alcoholic, yes, sir.
And non-biliary.
Non-biliary.
So tell me other causes of acute pancreatitis in this patient apart from alcoholic and biliary.
Hypertriglyceridemia is one of the causes. It's
Okay.
obese.
But that you are not listed in the investigation. But that's okay. Go ahead. Go ahead.
I would like to do a serum calcium to check for any calcium and parathormone to check for any parathyroid adenoma. It may
Suppose
cause it.
parathermone comes high. Now what do you do? Where does this patient land up into?
I would like to do a USG of neck then to look
You
for
find a
any
parathyroid.
adenoma.
I don't want to get into parathyroid adenoma. This. What is sestamibi scan and how accurate it is to localize parathyroid adenoma?
It is an investigation of choice for parathyroid adenoma and ectopic parathyroids.
In today's literature, 4D CT or versus sestamibi scan, which is superior?
The system maybe scan
No,
was
4D CT.
See, this is how people can get into trouble. I'm only asking you questions so that you realize that you should not lead people, especially examiners, into territory which you don't know. Be very careful. Okay, let's come back to pancreas.
Yes.
Pseudocyst of pancreas projecting into through the transverse mesocolon. You have decided a cystogegnostomy. Have you seen one?
no, sir.
No, it's okay. Does not matter. So you have not seen transcutaneous drainage. You have not seen cystogegnostomy. Have you seen a cystogastrostomy?
Yes, sir.
Very good. So tell me, laparoscopic cystogastrostomy, what did you see?
Sir, initially when we put in a first camera, we are able.
It starts with preparation, my dear. Planning, port placement, etc., etc. So tell me the first port, how it was put, and you saw.
The first port was umbilical, and there were two. The patient was in a split leg position.
Okay.
There were two ports, one in the left midclavicular line, one on the right midclavicular line,
No,
and
no, no, no,
one
no,
more.
no. One minute, 1 minute. Once you put in the umbilical or supraumbilical port, what do you see and decide your port placements?
A lump in the lesser sac means
Correct?
pushed lesser sac mass. We were able to see a bulge in the lesser sac.
Very good. Now, when you saw the bulge in the lesser sac, you saw the stomach, you saw
Yes,
the
sir.
transverse colon, and you decided to go in.
Yes, sir.
How did the surgeon decide where to put in the ports? What did he think that these angles that were created by these ports are going to be good for me to do a complete job?
For suturing, we form a triangle so that the point of the cyst is at the center of the triangle.
What
We
is the
pour
angle that is known, which is created between the two working instruments?
no idea, sir.
What is manipulation angle?
Sir, I don't think he's into it. He doesn't, he's not
No, no,
read
no,
into it.
but see, he has to know.
Yes.
He is only seeing and learning.
Hmm.
So I'm asking all these questions for other people to also realize that these are the things which these people learn by only seeing without knowing the basics. That's why I have brought out these questions. It's okay, Jaimil. Not an issue. Okay. Tell me, suturing becomes easy vertically or horizontally?
Vertically, sir. Means if the
Vertically. Why?
wound is
Why?
vertical,
Very good. Very good.
because
You are
both
correct.
the
Why?
angles, because the angle of the suture needle holder will be in a horizontal way.
You must have done a lot of abdominal closures, right? By now.
Yes, sir.
Yeah.
Yes, sir.
What is the angle that your needle holder and your left hand forcep make between the two when you're closing the abdomen? Approximately.
Perpendicular
I
means
don't want exact angle.
perpendicular almost, the left hand and the
No. Left hand and right hand, what are the angles that your needle holder and the forcep make when you're taking a closure suture?
around 30 degrees, something like.
That's the problem. When these are common things which we learn, which we don't even think about, and think about it. Same thing has to go on in laparoscopy, and you will become a good surgeon. So from tomorrow onwards, go ahead and look at all these minute things that go on, and you will do a good job. All the best to you in your future. My questions are over. Thank you.
Thank you, sir.
Tarun, sir, you would like to ask anything? Okay, I think it's not that. Janil, what is
Yes,
actually
sir.
cystogastrostommy is?
Uh, the anastomosis between the cyst wall and the posterior wall of the stomach.
Right. So what is the principle behind it? Why we do cystogastrostomy and not the external drainage?
Uh, because, sir, the risk of pancreatic fistula formation is less in the cystogastrostomy. If
Ah,
we have an external opening, there is a possibility of that.
right. So why if you do external drainage, chances of fistula are high?
Because if there is a ductal disruption, there will be a tract formation between the means
There
through
will
the
be
drain
ductal,
which we are
there
having.
will be ductal disruption. Then only there will be formation of pseudocyst. The point is which duct it disrupt, major, minor, depends. Do you understand?
Yes, sir.
So it is that to prevent, we do, what do you call it? Cystogastrostomy, other name is internal drainage,
Yes, sir.
right? That is the internal drainage. You should
Yes, sir.
understand. Why it is not a good anastomosis?
Because it's a pseudo wall. It's not the proper epithelium,
So what will
the
happen?
fibrous layer.
What
There's a
will
chance
happen?
of leak.
No, it's not a chance of leak. It is okay. It is any anastomosis will have. The point is that when the anastomosis between epithelium to epithelium, it will minimize, minimum stenosis will occur. Here the anastomosis epithelium with granulation. So in a long run, this opening will close, right?
Yes.
So why it is okay if it close?
It
So
will
that
lead
is the
to formation of
principle. If the
cyst
leak
again.
persists, anastomosis will not close. But if leak stops, anastomosis will also close. So keep that thing in mind. So is it many a time it is a temporary anastomosis we create to tide over the.
Yes, sir.
One more point in an investigation, do not forget to mention about amylase and lipase that we did not discuss, which is a very important. Suppose you have done today also serum amylase and it comes high, around 1000. What will you do?
It may indicate that the process of pancreatitis is currently
So
ongoing.
that is also one more point. You wait for the time being that you do not go in or operate. Right?
Yes, sir.
So what are the limitations of endoscopic neck? These are the few questions I had in mind. Endoscopic pseudocyst drainage or necrosectomy? Endoscopic. Sir was asking you the question. Limitation of endoscopic necrosectomy. If you know, say yes. Otherwise, we'll leave it.
Yes, sir. Don't know.
So one is a stent gets blocked. Bleeding can occur in absence of US. And one more point, it may take many sitting to remove necrosis because it's a slow process, very long time it may take. That is the. Similarly, you should know about retroperitoneoscopy and removal of the necrosis. That is the points. Sir, I think I have done enough. Mathur, sir?
Yeah,
I think
I think
he's, he,
examiners gets thumbs up.
yes, he was good. Not,
No. Examiners gets
yes,
thumbs up. Okay. And the examinee gets the thumbs down,
okay.
as far as I'm concerned.
Okay.
Okay.
It's okay. He will
But
learn. He will learn, but it's okay. Fine.
see, the critical
So only
presentation
point,
was
sir,
very
before you
good.
say, I will advise him one thing,
Yeah.
that Jainil, do not confuse USG with clinical. The clinical part is totally different than that. Do you understand that
Yes, sir.
ultrasonography may be suggestive of WOP, but we all were trying to tell you that put a pseudocyst there. And that's why do not rely on USG for your clinical management. Means you were describing USG finding as your clinical finding. Do you understand? And that created a problem. Second point, learn to take hint. If examiner is repeatedly coming there, that means you should have some understanding. Okay, I think they want pseudocysts. So let us say it. The reason is that when you talk of WOPN, there is nothing much to discuss. But when you talk of pseudocysts, discussion will be easier and better for you.
Yes, sir.
Those are the points I wanted to tell you. And do not remain hard and fast that this is the finding. There will always be variable. It should be clinical. That's it. Yes, sir.
Yeah, I agree with you. What you have actually pointed out, that's what it is. You don't try to fit your history into the uh, findings, okay? Or because you know the patient. You couldn't explain so many things which were asked in the history. So the history has to be where you can give the answer, ki, okay, this is what I suspect. Okay,
Okay, sir.
yeah. So
Super sir's comments, please.
Dr. Dalvi enjoyed your all discussion, but this is a classical kind of an mistake a student does
Yeah.
when he gets fixed to a diagnosis and then he tries to revolve around the diagnosis. You have to keep yourself open, and I think that's what examiners were trying to tell you. And then when you wait, so I think your history, you spoke very well, but when you started analyzing, there was a very fixity. And in the planning, as you rightly said, I think you have to have that clarity about Atlanta, what exactly you would like to do, what is step-up approach. And then the technical questions which Dr. Dalvi really asked are very important because see, we see it every day, but many times we don't realize why we are doing it. So it's important to critically look and do it. So I think Daniel, you did well, but I think I'm sure you could do a lot of better. I think, and thanks all to the examiners for bringing out such wonderful points.
Yeah. Okay, sir. Shall we take your leave? Thank you very much for calling me.
Thank you, everyone, for such a wonderful
Thank you,
session.
sir.
And we all enjoyed it. Thank you so much.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir. Good night, sir.